What's up, future respiratory therapist? Hey, in this video, we're going to be talking about alarms, but specifically the alarms associated with non-invasive ventilation. I'm going to tell you the two most commonly misunderstood alarms when it comes to non-invasive ventilation. Let's dive in. All right, so as I stated, today's all about alarms associated with non-invasive ventilation. And this is a screenshot of obviously some alarms for a particular device that you're probably familiar with. But in general, these are the alarms that you're going to be setting during non-invasive ventilation in most of your uses of non-invasive ventilation. Now, remember, so some key elements when we talk about non-invasive ventilation, and the first big key element that you want to remember is that when you're implementing non-invasive ventilation, you most likely are dealing with a patient who has a spontaneous respiratory rate. They are breathing spontaneously. We don't want apneic patients relying on a non-invasive ventilator. So your patient's going to be breathing spontaneously, which means you're going to have a greater variation in your volumes because your patient now has the ability to dictate their volume as well as their rate. So keep that in mind as we go through these and talk about these alarms so that makes sense on how you should set them appropriately. Now, this one here, you can see we start with a high rate and a low rate. Now, this is important because, again, your patient's going to be breathing spontaneously. Let's say your patient's breathing 20 times a minute on non-invasive ventilation. Well, you probably want to have your high rate set above that total rate. So the general rule of thumb, and there's no concrete exactly where do we set them, but the general rule of thumb is about 8 to 10 above the total rate. So if a patient is breathing 20 times a minute, you probably want to be notified if they exceed 28 to 30 times a minute. Why are they now having to breathe faster? You want the ventilator to be your eyes and ears for you while you're not in the room. That's what an alarm does. It serves that purpose to say, hey, where are you at? Come look at this patient. Something has changed outside of the parameters that you told me to set and to alarm you to. So that's what we're doing. So we want the high rate to be set to notify us if the patient starts to breathe over a certain rate, and total frequency. Now, the low rate is obviously the exact opposite. If you have a patient breathing 20 times a minute and suddenly maybe they get some pain medicine or some anxiety medication or a sedative or something for whatever reason, then you might see where that rate goes from 20 down to 6. Well, obviously, you would not want somebody's respiratory rate to go from 20 to 6 without you being notified. So the low rate is important because it gives you that indication as well. Okay, so we know that rate and tidal volume together make up minute ventilation. So we know minute ventilation is associated with CO2 removal. So if rate goes down, minute ventilation goes down, then CO2 goes up. We want to be notified of these changes. That's what your low rate is for, as well as your high rate. Now, the next one we see here is a high VT. The VT stands for tidal volume. Low VT stands for tidal volume also. This is a high tidal volume and a low tidal volume. Now, this one is obviously not set correctly because your high is 200 and your low is 140. That's a 60 ml difference. This patient must be breathing somewhere at around 175. And if they just increase it just a little bit to 205, it's going to say, hey, high tidal volume alarm, high tidal volume. Well, we don't need it to be set that tight, right? So let's just say you have a patient with a tidal volume. Again, spontaneously breathing patients are going to have greater variations in their volumes. This isn't like, volume control ventilation where you have a tidal volume of 500 dialed in and it should be 500 every single breath. That's not what we're talking about. So if you have a patient who is breathing obviously spontaneously and their tidal volumes, you watch them for a little bit and their tidal volumes are ranging anywhere from 300 to 550, then you're going to set your high tidal volume alarm approximately 100 to 150 mLs above that high tidal volume that you're observing from that patient. So let's say that the tidal volumes are ranging again 300 to 550, then I would probably set my tidal volume alarm, my high tidal volume alarm, somewhere around 700. And that would let me know if something excessive was to start to cause this patient to breathe too high. Now, the other problem with this is we are providing positive pressure therapy to our patient. It's just non-invasive. So remember, volutrauma is a thing. So we don't want our patients sitting there taking 900, 1100 ml tidal volumes. Maybe they're getting better. Maybe they're waking up. Maybe whatever it might be. Now the tidal volumes are excessively high. This alarm is going to notify you of that when set appropriately. Same thing with the low tidal volume. Patients breathing 300 to 550 range, variations in tidal volume, probably going to set that low tidal volume at about 200. Because I want to know if for whatever reason, just like with the respiratory rate, if that patient's ability to take an effective tidal volume decreases and I see those tidal volumes start to fall, then I want to be alerted of that so that I know that there is a change that I need to be aware of. Again, just like with rate, tidal volume goes down, minute volume goes down, CO2 goes up. I need to be aware of this. Okay. The low tidal volume is really good marker when you're dealing with maybe your neuromuscular patients who have periods and times of weakness where it may look fine while you're in the room, but they go to sleep and tidal volumes drop significantly. Something to pay attention to, something that you're going to use that tidal volume to alert you to. Now, also with the low tidal volume alarm, you could get this if there is a massive leak in the system. This typically is going to happen at the mask interface with the patient. So if they have a large leak, or like I said, they lay down, they go to sleep, they roll over, and the mask gets pushed to the side, and now they have a large leak. Well, if there's pressure and volume leaking out of the mask, then it's not going to be coming back to the ventilator to be assessed. And so you could see a low tidal volume also related to either a inappropriately fitting mask causing large leaks, or just manipulation of the mask that is causing large leaks. You know, the patient took the mask off, took a drink of water, put it back on, tightened it too tight, and now you've got the mask interface with the patient is folded over and crimpled up, and you've got a large leak happening. So you want to also consider, is my mask appropriate when I'm getting a low tidal volume alarm? Now, the next column we see here are our pressure alarms. This is our HIP, which is high inspiratory pressure, and then our LIP, our low inspiratory pressure. These are exactly what they sound like. During non-invasive ventilation, when you are applying an inspiratory pressure to that, basically either pressure support or EPAP, depending on what machine you're using and what the terminology for that machine is. If that pressure, when that pressure rises during inspiration, it's going to rise to a preset number. So let's say you have it set at 15 and the pressure is going to rise to 15. It shouldn't go to 22. If it does go to 22, something's going on. There may be an obstruction in the circuit. Maybe the patient is coughing excessively hard against the BiPAP. Maybe something is going on causing that pressure to be high in that circuit, and we want to know when that's happening. Now, as far as the low inspiratory pressure goes, this one is kind of tricky because this is an inspiratory pressure. So remember, if I told you that we're going during the inspiratory phase, raising the pressure to 15, but it only actually gets to 8, then did it get to 15? No, it did not. Why did it not get to 15? Likely there's a leak in the system. These two go hand in hand together. Very similar to mechanical ventilation alarms. If you have a leak in your system, you're likely going to get a low pressure alarm as well as a low volume alarm. And so we see there where that's where we're looking for with these low tidal volume and low pressure alarms. We need to say, okay, why is the pressure not being achieved and sustained? Oh, there's a leak in the system. You need to find it, refit the mask, whatever it might be. And then over here, we have a low VE. So the low VE is obviously minute ventilation. So if you have a patient who has a minute ventilation of 6.5 liters and you're like, that's perfect, I love where they're cruising right now, then that's good. But again, they get that pain medicine, they get that sedative, they get whatever reason, they go to sleep and their minute ventilation falls and drops. We want to know if that happens. And so that alarm right there is important. Now, this one right here is set on 0.9 liters. That's obviously not correctly set for anybody. We know normal minute ventilation, ballpark typical normal range is 5 to 7 liters per minute. If this alarm doesn't go off until that minute ventilation falls to zero point 0.9 liters, then there's a good chance that patient's CO2 is already high and they're probably acidotic. Now, again, just like the low tidal volume and the low pressure, if there's a leak in the mask and all of the volume is not coming back, then that might also cause our low minute ventilation alarm. So we see that it's not always tied to actual patient data. It's only patient data when the mask and the system is set up appropriately without any leaks. Then we're getting true data back from what our patient is actually doing. So we always have to ask ourselves, is there a leak? If you're not getting your low inspiratory pressure alarm, then you probably don't have a leak. But you're getting a low minute ventilation and a low tidal volume alarm, the patient probably needs more support. That's how that works. And then there's this last one down right here that's low inspiratory pressure time. So this one right here is set in seconds. So this is a 20-second, basically a 20-second window where it's going to let you know if that inspiratory pressure does not reach the setting we talked about with the low inspiratory pressure, right? But remember, these patients are spontaneously breathing. Their hands are free. They're trying to eat and drink and talk to people. So there's a lot of times where they will take the mask off or manipulate the mask, and that leak will cause this pressure not to be reached. Now, we probably don't need to be notified of that every single time. We probably just need to be notified of it if it's a continual problem that lasts longer than 20 seconds. That's when this alarm will let you know, hey, there's something going on here. We can't achieve our pressure. But if it's a one breath and it lasts and it fails to achieve that pressure over 8 seconds, and then the patient puts the mask back on and readjust it and everything is good, then you're not going to get a low inspiratory pressure because we didn't exceed the 20-second time limit that we have set here. Okay, now I told you there were two of these alarms that are most commonly misunderstood on where they should be set. I'm going to circle for them for you right now. It's the low inspiratory pressure, and it is also the low rate alarm when it comes to non-invasive therapy. Now, both of these are currently set incorrectly. They just happen to be. I mean, there's obviously multiple alarms that aren't set correctly here, but these two, by technical aspects on how does this alarm, it's not going to work set up like this, and I'm going to show you now how and why that is. So let's look at these settings here, okay? So another same ventilator. We've got an IPAP of 10. We've got an EPAP of 4. Let's just stop right there. We understand what that tells us, that we are going to start at a pressure of 4. Let me show you here. We're starting at 4 and we're going up to 10. So there's 4 and there's 10. So it's going to look like this. That's what our inspiratory phase is going to look like on our pressure waveform. Okay. Now remember, the low inspiratory pressure alarm is designed to tell you if the inspiratory pressure fails to reach that pressure based off of wherever the alarm is set. So let's go back and look at it. Where is that alarm set at? The low inspiratory pressure alarm is set at 2 centimeters of water pressure. So essentially, the alarm is set down here. Look, that alarm is never going to go off because we're holding at an EPAP or a PEEP level of 4 centimeters of water pressure. And so there's no way that alarm, we are above that alarm all of the time. And remember, it's going to alarm when we fail to get that high, when the inspiratory pressure does not get above that alarm setting. Well, we're above it all the time. So It's never going to go off. It's completely useless at this point in time. So what you want to remember and what you want to write down if you're taking notes is this: the low inspiratory pressure alarm. I just call it the LIP. The low inspiratory pressure alarm during non-invasive ventilation should always be bracketed between your PEEP or your EPAP and your set inspiratory pressure, those two. So right now we're set at 4 and 10, which means your lip should be set between these two. Now, when the next breath happens and it looks like this, we didn't get to the point, did we? This is going to be an active alarm now that says, hey, you failed to reach the minimum inspiratory pressure that you've told me to tell you about by setting the low inspiratory pressure alarm. It always has to be between EPAP and the inspiratory pressure. Okay, so keep that in mind. It's very, very important. Next time you're in front of one of these ventilators, I challenge you to look at it and tell me. Come back to this video and leave me a comment and say, yep, you're right. It's always set too low. And that's an incorrect usage of that alarm. It's not going to help you. Now, the other alarm that I told you we were going to circle that is commonly misset and misused is the low rate alarm. Okay, now remember, if we go back and look, our low rate is at 9 breaths per minute. Okay, now the patient's in charge of their respiratory rate. So they can breathe. They want to breathe 20, they want to breathe 18 times, perfectly fine. This is perfectly fine. And if it drops to 9, then the ventilator is going to let us know. Okay, that sounds good. But here's the problem. How's it going to drop to 9 when we have a backup rate of 12 set? You've got a respiratory rate set at 12 breaths per minute. How are we ever going to drop to 9? How are we ever going to know if our patient has stopped breathing when we have a set rate of 12 that's waiting there to kick in, that's going to deliver at least 12 breaths per minute? It's not. It doesn't work that way. So you need your rate alarm to at least be greater than whatever you have your backup rate set at. And that will let you know at the very least that, hey, this patient is not, something's going on here, because their spontaneous effort has dropped and we're pretty much kind of just cruising on the backup rate, and we don't want that. I don't see good outcomes with trying to ventilate somebody with a high backup rate. It just doesn't ever seem to work out very well. And so keep that in mind. You want that alarm to say, hey, your patient's spontaneous efforts are doing this. Okay. And remember, you got to think about that in conjunction with your set rate. Now, that's non-invasive ventilation specifically related to alarms. Remember the two most commonly misset ones: the low inspiratory pressure and the low respiratory rate. Keep that in mind as you work through. Hey, don't forget about the Respiratory Coach Academy. I've got several digital courses available here to help support you along your educational journey, or to use as refreshers, or just whatever. If you're just interested in learning more about respiratory therapy, I've got several courses here. Check the video link in the description below for a link to this page right here, and you can access any of the boot camps. I got my formulas course up, covers every formula in respiratory therapy, pharmacology, arterial blood gas, and then also the free resource class. This course here is completely free, so go check that out. I'm a respiratory coach here on YouTube. Stay here. Give me a like, give me a follow, and share this video. Leave me a comment if you have any thoughts on the video itself. Come follow me on Instagram and TikTok at Respiratory Coach, LinkedIn at Joe Lewis, and then finally send me an email, respiratorycoach@gmail.com. I'd love to interact with you, hear your thoughts on how are things going in your facility. What are y'all doing that's cool? What are y'all doing that's innovative? Just send me a message. I just love interacting with the respiratory therapy community. Remember, at the end of the day, average is easy. Don't be it.